Welcome everyone, and I think we'll go ahead and get started. So today, I'm happy to introduce my colleagues who will be sharing information with you. Michelle Schneiderman is from California Healthcare Foundation. You'll hear from her in a moment. My name is Julie Silas. I'm with Homebase. Grant Tui, I'm going to get it right, Tui Toti is from the Coalition of Homeless Service Providers in Monterey Bay and San Benito counties, and Christy Iannuzzi is with Alameda County Care Connect. Michelle, you want to go ahead and do an introduction?
Sure, thanks, Julie. Good morning, everyone, and welcome to the session. We're so glad you've joined us. I'm Michelle Schneiderman, Director of Advancing People-Centered Care at the California Healthcare Foundation. We are super excited to be here with you to try and make the case for leveraging information, otherwise known as data exchange, information exchange or data exchange, to move toward better partnerships between the healthcare and homeless services sectors. For those of you not familiar with CHCF, we're an independent, not-for-profit philanthropy working to improve the healthcare system for Californians with low incomes and people not well served by the status quo. Our priorities are to get everyone covered, deliver care better, and to make care just. Last year, the foundation launched work to improve healthcare for people experiencing homelessness, promoting care that's responsive, person-centered, and focused on the integration of physical health, behavioral health, and social needs. And the cornerstone of this integration work will really have to be robust and sustained partnerships among the healthcare, social service, and housing sectors. As part of this work, we commissioned Homebase to scan the state in order to learn more about how information or data sharing between the healthcare and homelessness sectors is happening in California now. We've published the results, which you can find on our website, and I'll put the link in the chat. We hope you walk away from today's webinar with a better sense of how information exchange can improve care and ultimately end homelessness in California. And I'll pass things back over to Julie.
Thanks, Michelle. So a little bit about Homebase. We are a nonprofit organization. We've been doing business around homelessness and working with communities all over the country to end homelessness for about 30 years, a little more than 30 years. We're subject matter experts in homelessness and cross-sector coordination and have a lot of background and experience working with the healthcare sector. We work at the federal, state, and local levels. We do a lot of work in California, and we do a range of assistance. We work on strategic planning, we do policy work, and we do a lot of work that helps people experiencing homelessness achieve housing stability and improve health and wellness. And one of the projects, the primary projects we've been working on is looking at how healthcare and homelessness systems in California have been collaborating, and particularly around data sharing. So this is just a quote from National Healthcare for the Homeless that really kind of hits home the need for collaboration across these two sectors. We know that people who are homeless have higher rates of illness and die on average 12 years sooner than the general US population. If you work with seniors, there are similar statistics about how much more quickly people age based on their homeless status. And so there's a real incentive to try and stem that by addressing housing and healthcare in collaboration with one another. And that's some of the work that we've been doing today. And this is really sort of an obvious Venn diagram. Most of you are coming either from the healthcare system or the homeless system of care, and you all know that oftentimes as you do the work on the ground, that the folks that you are working with are touching both your system and the other system. So if you're working in the homeless system of care, the same people that you're working with are also in the emergency room, have chronic complex care, working with hospitals and qualified health centers and doctors, and vice versa. So I think it's pretty obvious to this audience the importance of this type of collaboration. What we did in this breaking down silos, how to share data across the two sectors, which Michelle mentioned, was we looked at what folks were doing on the ground in terms of data sharing and the range of work that's going on in small communities and larger communities, robust work Despite all of those efforts, there are real challenges that people have experienced. And in California, particularly with whole person care, there have been a lot of opportunities to do that data sharing. And so in that effort that we found, we were able to see that there are some common patterns in terms of the challenges that communities have faced. And while there aren't any necessarily uniform solutions to how to overcome those challenges, communities have been creative and innovative and dedicated to overcoming some of those challenges. And that's a little bit of what we want to talk about today. And then also just reminding you that we have this paper that goes deep into these issues and gives a lot of community examples, some of which we'll share today, but it's definitely worth going through when you have more time. So we looked at some of the key benefits, or look at some of the key benefits of what it means to do cross-sector collaboration and data sharing. And the ability to communicate and work together results in better coordinated care, higher quality decision-making, the ability for communities to really think through, be more strategic with their policy development and their analytics, and then also results in administrative efficiencies, including cost savings when you pool resources together to collaborate on developing the systems. And here's and beneath those, of course, are some examples of what those benefits are. We also identified that there are 4 sort of big categories of challenges. One is privacy, and a lot of the issues with privacy are because you're looking at 2 different systems that have different privacy rules, and sometimes knowing that there are different privacy rules just creates a barrier in and of itself. And then other times there are barriers to overcoming those, and communities have tried to overcome those and address the barriers rather than just say, we're not going to do this because our systems are so different around privacy. But there are also issues around just differences in the systems themselves. They're siloed systems. They haven't worked together before. There aren't necessarily interdepartmental systems on the ground. And then there's also local politics, depending on where your homeless system sits in terms of what agency, and where your healthcare system sits with which agency. And it's very local. Another big area was interoperability, and that's really about the technology. There's different levels of technology sophistication. Sometimes you'll be working in a homeless system that has had a vendor doing their data that really has been around for a really long time and has only had to do that kind of data and may not have the technology or the functionality to be able to share data, or even to be able to export their data in a way that is readable by a more newer modern system. And you might also find that in the healthcare sector as well. And then the data quality is different. It's a little bit more controlling in the healthcare sector. Sometimes there's, 50, 100 different providers entering data into the homeless system of care. And so you get different levels of data quality, and how are you able to harmonize those to be able to make data sharing more effective? So those were some of the big challenges. But I will reassure you that in all the conversations we had, communities have done amazing work to overcome some of those challenges, and have done really amazing work to do data sharing to improve the lives of people who have complex care needs. And we'll talk a little bit about those, and then I'm going to turn it over to our partners to talk a little bit about what they've been doing. So, and these are just some of the things that communities have done, some of them that have been helpful for overcoming some of the challenges. When you're looking at privacy, for example, there's been a real effort to solicit participant consent. And so to doing things like broader releases of information, or explicit releases of information that make it clear who's going to be shared, and that sharing is going to be a little bit unusual. There may be, some folks have brought in expert outside legal counsel, where a county council might not have the privacy expertise to help negotiate what can be shared across 2 disparate agencies. And so they've brought in other legal experts to help overcome them. In technology, some have invested money in enhancing their technological functionality, or rather than try to have 2 systems talk, they've developed a shared care platform. So started fresh rather than trying to overcome the barriers that might exist between 2 systems. So there are a lot of different ways that communities have been able to bridge some of those gaps or to overcome some of those barriers to be able to do cross-sector collaboration, and the impacts have had far-ranging effects on people's day-to-day experience. So I'm going to share a few, just a few examples of local communities and then turn it over for our partners to talk about their experiences. So in Marin County, one of the things they did is they created a universal release of information that wasn't just the traditional one that you did in homeless system of care or that you might sign at a hospital or at a qualified health center. And they had 42 different entities sign that release of information. And one of the biggest things that that accomplished, they didn't have a data warehouse necessarily or a shared care platform, but they were able to actually talk to each other and have permission from the client or the patient to be able to pick up the phone and not worry, am I allowed to talk about this with this partner? And that really helped improve the ability. You know, sometimes it was finding someone, sometimes it was confirming someone's condition, sometimes it was getting more information than someone might be self-reporting. So that was one, that's a good example of a simple, small effort that could have far-ranging impacts. In Orange County, they started out through their Whole Person Care project, which was a project that was a pilot project that they were a recipient of, and it was a collaboration around cross-sector between healthcare and homeless system of care. And they joined, they created a data sharing relationship with their local health plan. And it was their Medicaid plan, and they were able to do work, and they were working only on behalf of the folks who happened to overlap the homeless system of care and the Medicaid health plans membership. But then later, they haven't had an opportunity to do broader departmental cross-agency collaboration, and they built on what had started out this small little project between homeless system of care and Medicaid to be something much bigger. And they created a governance committee of folks representing a lot of different agencies, and they're building a system that will have the privacy and security and compliance that everyone needs. So they started out small, but it created the platform to build something bigger. Another area in the city of Sacramento, they just didn't have the ability to do bi-directional data sharing. And what that means is homeless system of care is sharing with healthcare, and healthcare is sharing their data with the homeless system of care. Sometimes it's one way or the other way, but not always both. And Sacramento didn't feel like they had the capacity to do that bi-directional data sharing, but they still wanted to share information. So rather than not do anything at all, they just limited the bare minimum of information that they shared across the two to enable collaboration. And so they shared basically where the patient was and what their needs were. So they didn't share health issues, they didn't share names of doctors, but you knew that if someone was in the hospital, you knew they were in the hospital if you were trying to find them, or you knew that they needed a placement, they were in an emergency shelter and they were looking for stable or permanent housing. So that's the kind, those are all just some minimal examples. There's so many more in the paper, and we encourage you all to read them, but these are some examples of how communities have taken, you know, small steps that lead to bigger steps that can lead to even bigger steps through the process. So with that, I'm going to introduce Christy Iannuzzi, who actually has taken some pretty major steps in the County of Alameda. So I'm going to go ahead and turn it over to you, Christy.
Thanks, Julie. Next slide, thanks. So Alameda County has taken the opportunity with the Whole Person Care. For those of you who don't know that initiative, it's a California 1115 waiver opportunity for really focusing on high utilizing, primarily in the medical and mental health fields, and homeless population, and really developing a care coordination model and a data sharing model that really brings this group together. So as you can see, we're, most of the organizations that we have dealt with have access to maybe one system, maybe two, and really the Alameda County Social Health Information Exchange is a body of work that brings together data feeds from all of the sectors that you see here. and displaying that and redisclosing that information in a community health record, or CHR, to really coordinate that care and bring out a more whole person perspective for a client who is either receiving or not receiving care. And so we focused in the early phases on the clinical, behavioral health care, housing, and crisis response. We are also focused on the legal system, so jail, and the social aspects. And so next slide for me. The social health information exchange is really two things. It's a community of organizations that have agreed to share data under a set of agreements. So like Julie said, there's just this understanding and a set of rules around some of those in federal state regulations, but these rules that we understand, we will share data. And then there's the technical platform. And we took the funding from Whole Person Care really to take the opportunity to build a platform on a pilot level to manage whole person care, which was a relatively small population of a little under 100,000 people. But the idea would be that for the future, it would be managing all of the safety net of Alameda County, which is what it does today, to keep data secure, manage who can see what, and match identities across these disparate systems. The community health record was the first tool that we rolled out in 2019 that allowed providers, both on the clinical and on the housing side, to see a thin view of information. So really curated for relevant client utilization, diagnosis, and importantly, who is working with them. So who's in their social network, and who is in their care management network. Sometimes there are organizations who don't even know that they're holding the same client. Today, we have more than 30 organizations, 1,000 users, and 100 or more programs within those organizations that have been onboarding and are using that community health record, which is really important, right? Because as we're sharing information across those providers, that's how they stay connected to do that care coordination. Next slide. There's also, in order to build trust amongst these organizations, there are two really key documents. The data sharing agreement is one that is the one that I alluded to, where everybody is agreeing to contribute and receive data. It's all the same for everybody, but it also sets up the rules about how we'll operate and maintain an understanding about how we're going to use that data. We also have a patient consent or a client consent. It's integrated in the community health record, and it allows us to engage the consumer in what they will agree to share with providers across the care continuum. Now, there are HIPAA-covered entities that share a lot of information across that continuum. We also have this year, we have integrated non-HIPAA covered entities. And those entities, there must be explicit client consent in order for any data to be shared at all. But it's a big move because those clients, typically on the non-covered side, have really struggled to pull information together. And we're really facilitating that. Next slide. Really, our goals were to build a best of breed technology solution. We really wanted to be able to bring these diverse data sets, sectors, and build standards around the way that data is exchanged. It's really hard work because the data sets are so different. The clinical sets have been really relatively easy to pull together, but when you start to bring in jail data, housing data, even social services data, the paradigm in which that data is collected and shared is very different. And so we've also built a strong privacy and security infrastructure around this, which means that the people that are attributed to a particular organization, that means that we can say that Julie belongs to a particular organization and Christy belongs to another. And so that that attribution means that that organization will only see Julie's information and the other organization will only see Christy's. It's based on that strong relationship. And then patient consent as an integral part of that relationship and allowing patients to consent what can be seen. On the solution side, we have put together 3 really key vendors. Thrasis, who is our primary technology vendor, they have built all of the intelligence and the base behind this. We've also gotten a head start on all these clinical data feeds by bringing in CMT, or collective medical technology, which brings in a lot of these real-time data feeds so that we can send alerts in real time out to our care managers. And then Verato is a best of breed matching solution that really has allowed us to match more intelligently across all of these sectors. And then, as I said, our community health record is really the key portal to getting access to that information, linking attribution and patient consent in a really important way. Next slide. So our community health record is a combination of sort of key tools. There are client demographics and claims information, which you might see, but we've added some real-time alerts, including inpatient and ED sort of touches, right? So knowing when somebody has entered the hospital and when they have been released. Same on the jail side, knowing when someone has been booked, knowing that they're still in jail, and then more importantly, knowing when they've been released, which is one of their most vulnerable times. So those are sent in real time to the care managers so they know their panel of patients where they are in their crisis. The care team members are integrated through a couple of key ways. They can do that through messaging one another securely. They can share documents, or they can communicate in a shared care plan. And that shared care plan, while not asking for a lot of duplicate information, is really engaging in the client's shared care so that they're really only telling their story once. And that we're also leaning in where there are moments of crisis where we can give tips on how to best approach a client when they're in crisis. So really important, curated, actionable information, housing information for clinical providers, and clinical information for housing providers, really trying to intersector care coordination to promote that action. Next slide. The data that's available, lots of it. So we've got care team members and social information, Medi-Cal coverage, people fall in and out of Medi-Cal, really knowing where they are with that. Lots of clinical information and primary care medical home, which is very valuable, particularly both for the clinical members and for the housing team members. Mental health services, really this is a new set of data that's available both to clinical and housing providers that has not been available before. Coordinated entry information and housing program information coming directly from HMIS. As I mentioned, jail incarceration information, some public benefit information from social services, HIV test results, and relatively recently, we are including CCDs or discharge summaries that give a lot of really rich information at discharge. So that's really our system as a whole. I think this is my last slide. Any quick questions? I haven't been monitoring the questions and answer. So HR is managed quickly, and if I've got another minute, it's sponsored by Healthcare Services. The Whole Person Care Program, Alameda Care Connect, was sort of the sponsoring engine, but Healthcare Services Agency manages that system. Public health is a part of the Alameda County data sharing system. It's a division of Healthcare Services. So absolutely they are participants and users. And I don't know, whole person care. Yes, that there was, I think that's what that means. Whole person care was, eligibility was determined in that. And it's actually the key to the importance of this cross-sector system is it is a combination of utilization, housing status, and sometimes even jail information. So having access to this multi-sector system was important for eligibility. And for those of you who know what we're looking forward to in CalAIM, it's going to be a key system in helping these health plans understand what has traditionally not been something they've been able to lean into very much. So these kinds of systems are going to be really, really helpful. And it was a little abbreviated, but yes, health plans, hospitals, FQHC, housing providers, really wide set of community organizations are participating in both using the data and providing data to the system. I went really fast. I want to mark time.
Chrissy, there is one more question about community collaboration work and how that happened. Did it go more officially through the COC? And if so, was it broader than that? How did that go in terms of engaging beyond the agencies?
Sure. So the COC was a participant in the broader engagement of community providers. So they were a participant, and the formal platform was the Whole Person Care Healthcare Services sponsored AC Care Connect. So it really was a very formal, engaged process. There's a data governance committee. Someone from the COC actually sits on that data governance committee. So there is, if that's answering your question, there really is a sort of a broad community engagement in the system.
And then there's one more technical question offline. So when you're done, you might want to go look at it with some names and some specifics that not everyone might benefit from. So just directing your attention there. Another question was, how long did it take to create the CHR?
So interesting. We went into we did a little pilot kickoff that we ran for almost a year to get some lessons learned. So that ran for about a year, and that only took us about 2 months to set up. In the meantime, bringing all of these data streams together, because remember, the social health information exchange is the key to underlying the community health record. So it took us about a year from the moment that we procured until we actually launched the CHR. And we were running at a breakneck pace, really, because it's a 5-year program. We've gotten a little bit of extra time, one of the silver linings of the pandemic. So we've got a little bit of extra time to continue that development before we hand it off for sustainability to healthcare services as a whole. But really, we've been focused on, rapid stand up and learning on the ground.
Thank you. There's one other question, which I think I can help answer a little bit. Is this only unique to Alameda County? And one thing I wanted to share is, I think the project that Christy's working on is unique to Alameda County, but the effort to do the kind of work Alameda County is doing is widespread. So there's robust efforts in Sonoma County. They created an interdepartmental multidisciplinary team and partnered with, oh my God, who's the vendor? There's a vendor that I'm blanking out on. IBM, thank you. Oh my God. Anyway, they partnered with IBM and they created a data warehouse that is shared across multiple agencies. Their board of supervisors moved forward a motion to create this data warehouse. And so all agencies under the county were participating in it. And what they do is they identify specific cohorts that they want to collaborate on, and they pull the data from all the systems of each of those agencies around those cohorts and share that data. So it kind of, the data warehouse becomes a share care platform for those specific cohorts. And in San Diego County, it's another example of a big county doing this work. The nonprofit and healthcare system, one of the biggest hospitals down there, partnered with the 211 program and the local continuum of care to set up a community information exchange. And that folks, they have shared release of information, and the different agencies have different levels of data sharing that they do, but it created a shared care platform that people can use to help work together and collaborate on serving those with complex care needs. I'm going to hold off on more questions and use this as an opportunity. We just talked about 3 big projects that did a lot of work and created these multidisciplinary, multi-agency projects. But I'm going to turn it over to Grant now, and he's going to talk about it from the perspective of a small community and sort of how they went about this work in their community and how it created building blocks to do more. So Grant.
Hello, everybody. Thank you, Julie. My name is Grant Tuioti, and I am from Monterey County. I work for the Coalition of Homeless Services Providers, and we are the lead administrative entity for Monterey and San Benito County's continuum of care. And when it came to data sharing, we had these really big ideas that we really wanted to accomplish. We wanted to work with whole person care to create like a custom coordinated entry system that kind of integrated both data systems together. We wanted to build out our ability to break down silos amongst service providers themselves. And then we also wanted to build up our ability to do data analysis. We really wanted to look through things with like an equity lens, especially the race and ethnicity. But we ran into several challenges. The first one was our HMIS provider that we're using didn't have an API at the time. So we couldn't talk to systems very easily. So we had to try to figure out a way to troubleshoot that. And unfortunately, before we really got a chance to really dig in and be creative in that sense, the pandemic hit. We had to respond to COVID-19. And as devastating as COVID-19 was, we were able to work collaboratively in a way that we never were able to do before. We partnered with Monterey County's Department of Social Services to implement Project Roomkey in our community. And we created, we couldn't do APIs and anything fancy like that, but we just shared spreadsheets online to do with the clients that we shared through Project Roomkey. And then throughout that process, we really focused on building these relationships, meeting with our social services, meeting with whole person care, getting to know other health providers in the area and try to integrate them into our coordinated entry systems. Currently, what we're working on is we recently had a community hospital reach out to us to try to see if they can work with us to get into our coordinated entry system. We're working with Monterey County Behavioral Health to include some of their physicians into the system so that we can do referrals for clients that for those programs where their kind of notes and perspectives would help us with those referrals. And we're also working with Central Coast Alliance of Health, CCAH, and they're going to be they're a local health plan provider that we have over here. And they're going to be implementing CalAIM for our community. So we're working with them right now. So we're working on trying to find a way to do kind of a custom matching with our HMIS provider that we can then share data across both systems. And we're looking at a way to export both data out of the systems and kind of do a data warehouse potentially. We're super early in those discussions. And then we're working on building out data dashboards at the same time. So we're working towards those big dreams, and we're hyper focusing on continuing to build the relationships and then slowly building our capabilities, especially with HDIS system that came into play, which finally got our provider to build out this API that we're exploring what we can do with that. So that's kind of where we're at. We're really focusing on building those relationships and figuring out what we can do now and move forward with that.
Thank you, Grant. I want to just highlight a couple of things. So they started a long time ago and they had, as Grant said, had big dreams, and they didn't give up on those and went for small steps as it went forward. And some of those small steps were just continuing the conversations with partners and, you know, identifying where those barriers are, instead of letting those barriers stop them, coming up with creative solutions. So using an Excel spreadsheet, you know, to be able to do that. But you know, a lot of people who benefited from Project Roomkey benefited because of that spreadsheet. And then also the state. So I don't know if everyone has the same technology terminology, but an API is sort of a technological functionality that allows one system to talk to another. And if HMIS didn't have that system, so they did not have the technology that allowed their system to talk to any other system. But then when the state recently had all COCs, including their HMIS vendors, communicate with the state, as the state created a data warehouse for all the different homeless systems data, so that they could report out and have a better understanding about California-wide data on homeless systems of care. The HMIS vendors who didn't have that capability got motivated to have that capability. And so everyone in the local communities is going to benefit from that. So if they're like Grant, who had a vendor who couldn't do that, now vendors are able to do that. And that opened up an opportunity for this future endeavor that they're pursuing in Monterey to be able to use CalAIM and to partner under the CalAIM rubric to be able to help people access more services. So it's not the same, but also really important, and like having your head down and keeping on doing it and not giving up. And now they're in a place where they're now starting to talk about a data warehouse, which is pretty huge. So Jillian, are there other questions that we want to raise for either Christy or Grant or myself?
Yeah, I have one that was answered in writing, but I wanted, just sort of generally speaking, but I wanted to ask it of Christy and Grant specifically in case they want to share details about their particular program. So it's about how much clients are, how aware clients are of how much information is being shared when they're signing disclosure forms, and whether signing those forms is required to receive certain types of services. Kind of how is the data sharing program presented to clients? So I think it'd be good to hear from both Christy and Grant on that.
Sure. Grant, you want me to go first? So in Alameda, there is a lot of information that is shared via HIPAA. For HIPAA covered entities, they can see a lot of information without direct client consent. And that is because they're HIPAA covered and because they have essentially, not in the SUD sense, but a treating provider relationship. So they have engaged in the client's care. There are a couple of exceptions to that. One is HIV, that there has to be explicit consent there. Social services data, there has to be explicit consent. So that data is hidden in the system until that consent is received. On the non-covered entity side, I think I mentioned this, explicit consent must be received from the client. So that's to share any information with non-covered entities. And that is explained to them. We have a peer-reviewed, plain English ISA, that's the information sharing authorization, that does explain very clearly what's being shared with whom. So I'm hoping that answers your question.
Grant, do you have anything to add?
Yeah, I can jump in a little bit. So for us, we're just starting having those conversations because we're just starting to talk about data warehouse. So we're talking about, because right now what we have is in HMIS, we have in our ROI, it says that people amongst our service provider system can communicate. We let our clients know that that's the case. So we're talking about how to move beyond that is something that's very new for us that we're trying to figure out. So that's kind of where we're at right now in our community.
Great. I can talk a little bit about a couple other communities, at least one that I know of. So Ventura County created a different ROI in order to do more data sharing. And when they first put it out in the community of folks they were working with who had healthcare or homeless system issues, people were really wary of signing it. And so people were reading it. It wasn't, they're not just signing these, without looking at them. And when Ventura County experienced that, what they did is they went through a whole training and education system for their staff. And what they did is they talked to their staff about what the value of this more universal data sharing agreement was, and spent some time training staff so that staff was more and better equipped to answer the questions of people who would be releasing their information. And they saw a huge change in terms of people's willingness when staff was able to answer the questions and explain what the value was and explain what the purpose was, is to actually help coordinate care. So that they didn't have to produce documents as often, they didn't have to tell their story over and over again. And so once they had a better understanding of it, so people are, at least in Ventura County, people were reading it, and Ventura County did more in response to people's wariness to help them understand. And that was through training staff. Other questions, Jillian?
I think this one is for Christy specifically, and it's asking if the social health information exchange and the health information exchange are connected. Okay.
They are the same thing. So the health information exchange in Alameda County has a social component to it, which means we integrated housing, jail, social services, and we'll continue to add more social determinants of health. And so it is a single system that follows all the same rules and guidelines. So has all the same technical infrastructure.
Christy. And then this question again is for, I think both, or would be good for both Grant and Christy, but it's basically about the scope of your programs or the scope of the populations of folks that are kind of parts of these or have their information in these exchanges. So they're asking about total population served.
I can answer that two ways. So there are about close to 1.5 million unique identities in the system. We're serving in the safety net right now, something in the neighborhood of 400,000. And remember, that's because they're crossing a bunch of different sectors. So while we're focusing primarily on uninsured and Medi-Cal eligible.
Thanks, Christy. And Grant, do you have a sense?
Yeah, so I guess I can answer two ways as well. So for our much smaller collaboration project that we did, which was Project Roomkey, we served about 179 individuals, about 150 households for that project over the past year. And then for our wider system, I think according to like the past 2019 pick count, I think we had about 2,500, give or take, people who are experiencing homelessness in our community, which we try to incorporate in our provider network. So that's kind of where we're focused at. And then yeah.
Great, thanks. Actually, there have been a couple of questions that are sort of related, so I'll just ask them kind of generally, but the most recent question just came and was specifically asking if Alameda County uses a standardized screening tool for social determinants of health throughout the system. So I'll let you answer that, Christy, specifically, but I also, we've gotten some questions and tend to get these kinds of questions about like the extent to which any of the data sharing agreements or templates or tools that you two are using in your systems are available for people to look at or share. So I'll ask that as kind of a follow-up question too for both of you.
We don't, like Grant, we have a Project Roomkey where there are some standardized screening tools that are used, but across the community, in this particular system, there's coordinated entry, there's the Roomkey system where we do some standardized screening, but we don't use this tool right now to do actually any sort of screening, just because there are lots of different processes in each agency. So we're not doing that yet. And we can share some documents. I think a lot of them are sort of living documents, and so they're changing all the time, but if there's a way to share some of our standard documents, I think I'd have to check with my department, but I think we're open to doing it.
Julie, you're muted.
Yeah, thank you. Sorry. I will just say that we are working on a follow-up project to this based on that type of a question, that people are really looking for practical action steps to how to do this, and some examples of what a data sharing agreement looks like, or what a universal ROI looks like, and sort of like step by step some generic ways that you can go about doing this. We're hoping, and that's also with support from California Healthcare Foundation. So we're hoping to do that sometime having that ready sometime in 2022. And that will include some of the things you're asking for, like examples of how they've done, templates or that kind of stuff. So hopefully that will be available, and we'll make sure that we announce it to folks who registered for this webinar as well.
May I answer Tyler Harmon's question? Because I think this is an important example of how the community health record really has been very helpful in housing prioritization. Knowing some of the clinical and disability information that is available on the clinical side for housing, I think has been incredibly helpful. And, knowing if someone has a HIV and they're willing to share that certainly is a valuable piece of information, but also being able to share documents regarding quick disability applications, quick notes from doctors, things like that, that really kind of move this, what's a process that stalls. I think this has been a really important tool.
Thanks, Christy. Yeah, you beat me to that question. I'm glad you saw it and answered it, though. Another question that I was actually just about to answer in writing, but I think might be helpful to say aloud, is about whether you're able to track clients when they move from community to community. And on the sort of homelessness response system side, or from HMIS, the answer is usually no, but it might be helpful to know a little bit more details about, at least on the healthcare side, if there's any ability to track as people move around.
Yeah, I mean, for us, knowing that a client has left the county is typically done through the meds system. So when I typically know when somebody has gone to another county, if their Medi-Cal information has changed. So that's usually my first clue. And also, we can also see them utilizing another county. So the great part about collective medical technology is their data comes from all over the Bay Area. And so if you say, for example, notice that someone is exclusively utilizing in San Francisco, Contra Costa, or even farther away, that is an indication that they may not be living in Alameda County anymore. So I think there are a lot of clues that start to really point at leaving the agency, leaving the county.
I saw Steve's question about data warehouse and not starting from scratch and being able to build on what Alameda County is doing. And I will say that I know that's happening for Sonoma County, and Christy, you can answer for your all county, but in Sonoma County, they are doing this work and they have this data warehouse, and then Orange County is developing their own. So Orange County is the county where I talked a little bit about where it started out with just the homeless system of care and the local Medicaid plan. And now they're going to something bigger. And what they're building on bigger is building off of all the great work that already happened in Sonoma County. So you can start seeing that where all the great work that people did on the ground are now other communities are starting to adopt. So Christy, I don't know if you've had any experience with that or any solicitations for that kind of.
We haven't had any solicitations yet. I think there's a great opportunity to leverage this model and build on it. And I think there's some great economies of scale that can be gained from the system. That's exactly what this was designed to do, was to scale up. And so it has that potential to scale up. It isn't anything that we're talking about now because whole person care is just now closing out. And I think everybody's scrambling for CalAIM, but I think that's one of the challenges, right? Is CalAIM is right around the corner, and there are a lot of organizations that are just not ready for this kind of big data lift. And so I do think we have some, very interesting structure that could be leveraged if there was some interest.
I see your question about Orange County. Thank you, Christy, about who the champion in Orange County is. And I am not remembering off the top of my head, but it is in the paper. So it will tell you which department. I can't remember exactly. And then also our information will be on the last slide, and you're welcome to email me and I can follow up with you with more details about that. I also want to go back to one thing that Christy said, which is, I think it came from a question, is it used for prioritization? And we just know, and especially something Grant recognized about data sharing in terms of race and equity issues. We know that a lot of populations are uncomfortable self-reporting for a whole host of systemic racism and root causes of homelessness issues. And what the data sharing cross collaboration really allows is for once people are willing to have their data shared, it allows that information to come in so that people are prioritized more than self-reporting, which is what a lot of our system currently does in terms of homelessness prioritization, is a lot of self-reporting. And so it does create opportunities to get more accurate information about someone's experience of homelessness to be able to help prioritize that might not come out with self-reporting. So that's one of the other benefits. I know are there any more questions?
Nope. Not at the moment.
So I can talk a little bit about where we're headed. Hold on a second. So first of all, here are the Breaking Down Silos paper, which is in detail, and I know that Michelle put that in the chat. And then also Homebase has a website where we have that posted. And this is a part of a 3-part webinar, the last of a 3-part webinar series that really was created, and many of you may have been the other 2 webinars, to help understand a little bit more about the coordinated entry system and the homeless system of care for healthcare providers. And both of those webinars are on our website, this website that's listed up here, as well as a primer on homeless system and coordinated entry kind of 101 that helps folks not only understand some of the terminology and some of the unique ways that the homeless system of care is structured, but also is written particularly so that healthcare entities that want to get more engaged with the homeless system of care can see themselves there, and where are their opportunities to tap in, how to get involved in coordinated entry, how to share information. And it also has at the end a list of websites for all the COCs all over the state of California. So that's a resource for folks. And again, the webinars, if you didn't attend them, are available on that website. So you can just watch them from the website. And as I said earlier, we're working on a project coming up with a toolkit or guide that will help folks in smaller communities and communities that haven't started this yet, put together building blocks to be able to do all levels of data sharing and collaboration across sectors. So we will let you all know when that is available. And our contact information is on the next screen. And you're welcome to reach out to us for more information and to ask any further questions. So I'll just open it up again. If anyone has any other questions, the Q&A is there. And otherwise, we'll sit for a few minutes. I don't know if our speakers want to say anything more. I really appreciate all of you, but go ahead and open it up if you have any last words or anything you'd like to share with the audience. Well, I just want to thank both Christy and Grant for all the hard work you're doing and the models that you provide to the communities. Really appreciate all your work. Appreciate California Healthcare Foundation for supporting this work, and all of you who were interested in being on this conversation and interested in doing this work. We support you. We know there's huge value in cross-sector collaboration, and hope to see you in the future as this goes forward. So thank you all.